Hi and welcome back to another video of Medic Notes. This video is on pituitary adenoma. Let's look at the anatomy of the pituitary gland. Above it is the optic chiasma, classically causing bitemporal hemianopia if compressed, but any visual field defect may occur. Other structures there are pituitary stalk, hypothalamus, and temporal lobes. Below the gland is the sphenoid sinus and nasopharynx. Lateral structures include cavernous sinus, internal carotid arteries, 3, 4, 5, 6 cranial nerves. Expanding pituitary tumors may also compromise remaining anterior pituitary function, but rarely affect posterior pituitary hormones. Pituitary adenoma are tumors of the anterior pituitary. Most pituitary tumors are slow-growing and benign. Microadenoma is a tumor less than 10 mm, while macroadenoma describes a tumor larger than 10 mm. Giant pituitary tumors are bigger than 40 mm. There are functioning pituitary adenoma in which the cell type that composes them causes increased secretion of one or multiple hormones of the anterior pituitary. Alternatively, there are non-functioning adenoma that do not secrete hormones, but they can potentially compress the surrounding areas of the anterior pituitary, leading to hormonal deficiencies. The pathogenesis of pituitary adenoma remains unknown. Most of the pituitary adenoma are sporadic. In a study from Iceland, 43% were non-functioning adenoma, 40% prolactin-secreting adenoma, 11% growth hormone-secreting adenoma, and 6% adrenocorticotropic hormone-secreting adenoma. The presentation of pituitary adenoma depends on tumor size and functional status. Pituitary microadenoma is usually an incidental finding on MRI head. Patients are asymptomatic unless the tumor is hormonally active. Pituitary macroadenoma presents with mass effects and potentially hormonal deficiency or hormonal excess. For its clinical presentation, symptoms from mass effect include visual impairment, most commonly bitemporal hemianopia, followed by homonymous effects. Other symptoms are headache, and hormonal deficiency such as gonadotropin deficiency, causing amenorrhea in females and erectile dysfunction in males. Growth hormone deficiency in adults leads to fatigue and weight gain. Thyroid-stimulating hormone deficiency symptoms are weight gain, fatigue, cold intolerance, and constipation, and ACTH deficiency presents with fatigue, arthralgia, weight loss, low blood pressure, dizziness, nausea, vomiting, and abdominal pain. Whereas for functioning adenoma, prolactin-secreting adenoma, females present with amenorrhea and galactorrhea while men present with erectile dysfunction and gynecomastia. GH-secreting adenoma. Presentation includes headaches, vision changes, an increase in ring or shoe size, arthritis, carpal tunnel syndrome, and excessive sweating. Clinically, patients have coarse facial features, frontal bossing, enlarged nose, prognathism, enlarged tongue, and skin tags. Other comorbidities like hypertension, cardiomyopathy, obstructive sleep apnea, and multiple colonic polyps may be present at the time of diagnosis. ACTH-secreting adenoma, also called Cushing disease. Presence with weight gain, muscle weakness, mood disorders, easy bruising, and multiple fractures. Clinical features include a round face, facial plethora, supraclavicular fat, ecchymosis, and purple striae on the abdominal area and armpits. TSH-secreting adenoma. Patients have symptoms of palpitations, arrhythmias, and weight loss. On exam, they may have tremors and a goiter. For investigation, most pituitary adenoma are detected incidentally on routine CT imaging. An MRI with gadolinium is necessary for the distinction of a mass from an aneurysm and to assess for hemorrhage into the mass. Investigations include blood tests to check hormone levels. For treatment of non-functioning adenoma, transsphenoidal resection is recommended in patients with macroadenomas and if there is visual field deficit due to tumor. Other visual abnormalities as ophthalmoplegia, compression of the optic nerves or chiasm on imaging, pituitary apoplexy with visual disturbance. Loss of endocrine function, significant growth of pituitary tumor over time. After surgery, there is usually an improvement in visual symptoms and hormonal dysfunction in most patients. Radiotherapy is a consideration in patients with persistent residual or recurrent tumor. Whereas for individual functioning tumors, for prolactin-secreting adenoma, treatment include dopamine agonist like cabergoline and bromocriptine, transsphenoidal surgery, and radiation therapy. For GH-secreting adenoma, somatostatin analog icoctreotide, surgery and radiotherapy. ACTH-secreting adenoma, dopamine agonist or SSA, adrenalectomy, and radiotherapy. The prognosis of pituitary adenoma depends on its being functioning or non-functioning. The non-functioning adenoma and prolactinomas have an excellent prognosis if treated promptly with surgery and medical therapy. Functioning adenoma like Cushing's disease and acromegaly are associated with several other comorbidities and complications. That's all for this video. Thank you.